everyone. Deb said she had a story about me. I'm glad it was that one. It could have been much worse. Thanks so much, Deb and Turning Point, for inviting me to speak today. It's great to be talking in front of this room of passionate experts, which also makes you quite an intimidating audience. And I'm sure lots of you know a lot about what I'm going to talk about, probably more than me in some instances, or many instances. You'll know a lot of this already, I'm sure, but hopefully it's going to set the scene for the rest of the day. So I'm going to be talking about Nitazenes, or Nitazenes, depending on how you want to say it. Who is this bold man that has a body? So I'm a public health consultant with a background in medicine, and I'm currently doing a PhD at the University of Bristol about reducing stigma towards people who use drugs. My other roles, I'm the public health lead for the national programme on substance use mortality based in King's College London, and I co-chair the Faculty of Public Health Drug Special Interest Group. The Faculty of Public Health is the professional body for the public health workforce in the UK. And I also volunteer for the Loop. I mentioned that in case anyone will think that's a conflict of interest, because, spoiler alert, later on I'm going to say that I think drug checking is a good idea. So this is what we're talking about today. So a bit of background on the drug-related death crisis that we face, what Nitazenes or Nitazenes are, where they're being detected, some data on deaths related to Nitazenes, which comes from the National Programme on Substance Use Mortality, and then a bit about the context, why we're seeing more of these drugs, and what we might do, again, spoiler alert, harm reduction. So you're going to see this graph a lot of times today, it seems, but this is the drug-related death rates across the 4 nations of the UK. So Scotland has the highest drug-related death rate in Europe, which has more than doubled over the last decade. And we've also seen big increases in England, Wales, and Northern Ireland. And this is a public health crisis. In some parts of the country, this is a public health emergency where services are being overwhelmed by these deaths and the harms. So we have a lot of work to do, and as Deb has pointed out, every one of these is a human being, and we need to remember that. But it's also very important to note that in these figures, a lot of the deaths related to Nitazenes are not reflected here yet because of the delay between people dying and coroner investigations before the data comes into this. So we are probably, unfortunately, going to see an increase in drug-related deaths, and we wanted to raise awareness of this, and that's why we published this article earlier this year in the Lancet Public Health. And this is why we're particularly worried. So we can't compare the UK or the US directly. There's different contexts here. There's different socioeconomic contexts which are associated with more harmful patterns of drug use. There's different structures of healthcare services, of social services, of drug services. There's different specific drugs involved, different smuggling routes, different gangs. However, the similarity here is in 2012, 2013, in the US, fentanyl began to adulterate heroin supplies before it substituted the supplies in many areas. And they saw this really shocking increase in drug-related deaths that followed that. In the UK, we have Nitazenes, a similar family of very potent synthetic opioids proliferating. And the worst case scenario is we're going to see this really massive increase in drug-related deaths here. So what are Nitazenes? Again, probably everyone knows this already, but just to check we're all on the same page. So this is a class of synthetic opioids. So it's not a single drug, it's a family of drugs which is characterized by its structure. There's lots of different Nitazenes. I think there are 16 controlled under the Misuse of Drugs Act, and there's about to be the generic classification to control the others. And there will be more of these drugs as people keep changing this structure and adding bits to the compounds which can make the drugs more or less potent. They're synthetics, they're made in a laboratory from chemicals, they're not made from plants, and they are opioids, which means they work on opioid receptors in the brain. They're not opiates. Opiates are derived from the opium poppy, like heroin. All opiates are opioids because they all work on your opioid receptors, but not all opioids are opiates because some opioids are synthetic, like Nitazenes. Currently in the UK, we're mostly seeing these drugs sold as an adulterant or contaminant of other drugs, but we're already seeing people who are intending to use them. And what could happen here is the substitution for heroin supplies with these much more potent and more dangerous drugs. And I think the last point here is probably the most important. I'm definitely not a chemist, but as I understand it, these drugs are quite easy to make. They're cheap to make. You don't need big fields of poppies to do so. So it's going to be very hard for kind of a drug control paradigm to stop these drugs from spreading. Nitazenes were developed in the 1950s in Switzerland as a medication, but they were never marketed due to the associated risk of overdose. Since then, there were sporadic reports of nitazenes on the unregulated drug supply. So I'm aware of instances in Russia and the US over the last couple of decades. But it's only the last few years that we've really seen these drugs proliferate globally, with 13 different nitazenes reported to the UN between 2019 and 2023. And as far as I'm aware, they've been detected everywhere except for Antarctica in terms of the continents. Because this market is unregulated, we don't always know where these drugs are coming from, but at least some of them seem to be coming from China and some other countries in Asia. The potency of nitazenes varies depending on the specific drug. So obviously fentanyl and heroin aren't nitazenes, but they're included here for comparison. So some of the nitazenes, I think there's one which is less potent than heroin, at least one. But other drugs have a similar potency to fentanyl, and etonitazene is 10 times more potent than fentanyl, which is 500 times more potent than heroin. So you need a tiny amount of some of these drugs to potentially cause a fatal overdose. This data is from the excellent Weathernos. I'm sure everyone knows this service, funded by Public Health Wales. So members of the public or professionals can post substances to Weathernos, who do a range of laboratory tests and put the results online. And the really important thing here, like we have with drug checking, is that we get to see what people think the drugs are and what they actually are. And it's important to note that this isn't necessarily a reflection of the whole drug market. These are drugs that people have the kind of capacity and want to get tested. So it might be instances where they've tried it and they thought it was a bit strange, they wanted to find out what it was. And if someone was experiencing heroin dependence, they might be less likely to use this service, and because it can take up to 2 weeks to get the result. But nonetheless, we get to see kind of the range of drugs where nitazenes are being detected. So interestingly, benzodiazepines were the substance where nitazenes were most commonly detected, and also oxycodone pills. And there's a whole range of other drugs, and some of these are just weird, right? So 2CB, which I'm sure people know is a stimulant and hallucinogen. It has very different desired effects to nitazenes. Potentially, so that 2CB, we'll see on the next slide, was just a little yellow pill. So it might be people getting their drugs mixed up. They might have got their benzo bag and their 2CB bag mixed up. Potentially, some of this could be contamination, but we have to recognize it's possible that sometimes, if you can think of something in this massive world, it happens, and it might be that sometimes people are doing this intentionally. These are some of the pictures from Weathernos, and I think the benzodiazepines are the most interesting and shocking. So these look like drugs you'll get from the pharmacy, but these are street benzos that have nitazenes in them. Also being found in pills and substances that look like heroin. This cannabis was actually synthetic cannabinoids with nitazene, one nitazene also detected in it. So people at risk, this isn't just people who use opioids, and amongst the people who use opioids, it's not just people who are injecting heroin. It could be people who are buying oxycodone online to manage their pain if they can't get that from an NHS service. Also, obviously, people who use benzodiazepines, and that's not just people using street benzos who experience dependence. It could be people who use benzos to come down or sleep after using stimulants. And again, people buying medications online for anxiety to self-medicate. But potentially also people using other drugs as well. And I think the real challenge we have with nitazenes, given historically a lot of messaging around drugs hasn't been fantastic, is communicating these very real risks to people who use drugs without potentially overemphasizing some of the less common adulteration where people might just not believe it because it seems weird. So how do we communicate that it's happening and encourage people to take actions that will keep them safer? In terms of the deaths related to nitazenes in the UK, so you might have seen this figure from the National Crime Agency. I think this was published back in August. And this was published in June. And in the last year, the National Crime Agency reported 230 fatalities related to nitazenes. I think just 2 months after that, they published another figure, and it was 284. So the number of deaths is increasing very rapidly. This data from the National Crime Agency, this will be anyone who's died when nitazenes were detected. So it could be someone took a nitazene and then they were in a car accident. They'd come up in those figures. Why is this happening? So I'm sure everyone is aware of what's happening in Afghanistan. So I think it was 2021, the Taliban introduced a religious edict which bans the cultivation of poppies. And then there was this massive reduction in opium poppy cultivation. So the pink dots on the left are poppy fields, and they've all but disappeared in 2023. There are as I understand it, intelligence suggests there are quite large stockpiles of opium remaining. However, if your business was selling heroin and you saw this happening, this is a big risk to your business model. So I think it's very likely that people are beginning to try and innovate and potentially going to nitazenes, which they can produce without those opium poppies. Last week, I was in a conference in Strasbourg of the Pompidou Group of the Council of Europe, and all of the kind of drug control leads around Europe and the world were there, so senior police, border force. And in the first presentation, there was someone presenting on seizures of drugs in the Balkans. Heroin seizures had gone down by 70%, and novel psychoactive substance seizures had gone up by more than 900%. They were still quite a lot lower, but that's very concerning. I don't think I'm meant to share that data, so don't tell anyone. The interesting thing about this is after that first talk, everyone was like, oh, this is very worrying. Like, obviously, this could be very bad. But then other talks were talking about the amazing operations they were doing to seize more heroin. And I think there's no bigger indictment or demonstration of the internal inconsistencies of the current paradigm than this, because perhaps we shouldn't be seizing that heroin if that's driving these problems. Regardless of what happens in Afghanistan, I think nitazenes are here to stay because they're easy to produce. They don't require large crops, which people can eradicate, which the weather will affect. They can be produced in underground laboratories from pretty easy-to-get chemicals. So I think this was probably always going to happen. Also, you need much smaller quantities of these drugs because they're much more potent, so they're easier to hide, they're easier to smuggle. And this was all, I think this was 2023, the UN World Drug Report highlighted the increasing proliferation of synthetic drugs for these reasons. And this isn't the beginning of the story. So between 1997 and 2021, nearly 900 drugs were newly discovered on the European drug market. And obviously there's lots of other adulterants of concern. So fentanyl, benzoanalogues, synthetic cannabinoids, xylazine, cathinones. And I think, yeah, it's not the beginning of the story, and it's probably not the end of the story. We have to think about nitazenes now, but we also need to think about what's next. So what do we do about this? So I don't need to tell this room, OST is great. There's loads of evidence. This has a whole range of benefits in terms of improving quality of life, reducing deaths from a range of different reasons. It's also going to reduce the profits for drug markets, potentially more cost effectively than kind of the policing approaches that are used. But there are lots of people who could benefit from OST who are not currently receiving it. So we actually do really well in the UK. So I think we've got about a 50% coverage of potentially eligible people, which is much higher. Much higher than a lot of other countries. But there are still more people there who could be accessing these services. So how do we get more people in those services, get them receiving OST? So again, I don't need to tell anyone, there's been this big injection of money from the drug strategy. And although it varies area to area, as I understand it, we haven't seen a big uptick in the numbers of people accessing treatment. To be fair, I mean, after a decade of disinvestment, there's a lot of work to do to build those services up, to create those treatment spaces. But it still does raise some questions about what more we need to be doing, how we can make OST more appealing to more people. So I'm a professional emailer, and I am in the university all the time. I'm not on the front line. I don't see how these services work. But from talking to people who do, a lot of drug services seem to be designed for middle-aged white men who inject drugs. And there's a broader populations here who we need to be bringing into those services by making them more inclusive and more tailored to different populations. My PhD is on stigma. I was going to say I love stigma. I don't love stigma. That's exactly the point of the PhD. But clearly, we need to address stigma. It's not just the stigma that people experience in services. It's the stigma that people experience because they're associated with those services, which I think is a really key barrier to many people accessing them. Going into or leaving hospital or going into or leaving prison are key risk points where people can come off OST. There's more we need to do to try and make sure that treatment continues through those periods. And then there's questions about lower threshold prescribing. So again, professional emailer, not involved in delivering OST, but as I understand it, in some areas it can take 2 weeks to start someone on OST. I was in Portugal a few weeks ago, and I went to visit a mobile methadone van, and they would start people on OST in 15 minutes. So there's more potentially that we can be doing to, when we get those key periods, when people are interested and want to start an OST, to start it as quickly as possible. Also reducing some of the barriers, reducing some of the control perhaps on the people who are receiving it to make it more appealing. And the kind of, a big example of this lower threshold prescribing, something that they're calling safer supply in Canada. There are different models where, for instance, one in British Columbia, people will present, and in British Columbia there's loads of fentanyl. People can come and they can be given a week of opioids or stimulants with no follow-up, because their alternative is they are using probably fentanyl. And there's a burgeoning evidence base that shows that that has massively decreased deaths in some areas. And as nitazenes become more of an issue here, I think this is the sort of thing perhaps we need to be thinking about. Also in different countries, different opioid medications are used for OST, and we have a relatively small offer here, and there's much more work to be done in terms of which OST is most effective, what doses are needed for these more potent opioids. And particularly, like, the best evidence base for anything in drugs, drug services, is diamorphine-assisted therapy, and it's not something that's offered widely in the UK. We also need to think about how drug services can meet the needs and be more appealing to people who use other drugs, so benzos. So in the Orange Book, you can offer tapering doses of benzos in drug services, but I don't think that happens in a lot of areas. But also there's these questions that have been talked about for a long time now about benzodiazepine substitution therapy. I think there's going to be a study starting in the UK soon exploring the potential benefits of this. And I think the arguments for that approach are potentially getting more important and pertinent, given that benzos are frequently being adulterated with nitazenes. Also, people who use stimulants, it's quite difficult to engage those people in services because they're not offered anything specifically. In Canada, safer inhalation pipes are offered in lots of services to people who smoke crack. And that's something that's being studied by Magdalena Harris in a few areas around the country. I think there's a presentation on that today, actually. And then harm reduction more broadly, what else should we be doing? So I definitely don't need to tell anyone this, but there's been debates about drug consumption rooms, overdose prevention centres, safer injecting facilities, whatever you want to call them, for decades now. Despite many calls on the government to make these services more available, we're only just about to get the first sanctioned site in Glasgow, which should be opening any day now, I believe. But clearly, these services need to be available more widely. In some areas of the world, there's been drug consumption rooms for more than 30 years, and there's a really good evidence base that they work. But also, I think a lot of this debate has become really centered on this shiny drug consumption room, this specific site, which, because of the nature of it, is only going to be accessible to a relatively small amount of people who live in the surrounding area. But we know where people use drugs. Like, lots of people inject drugs in housing for people who are experiencing homelessness. And there's much more that could be done in those sites for a very cost-effective way. You have a room where people can use drugs, or someone is about to use drugs and they go to reception, they say, I'm just going to inject, can you check on me in 15 minutes? But because of our policies and the way that these services are set up, more likely that person would be ejected in some settings for using drugs. Also in British Columbia, they have drug consumption rooms next to hospitals, next to health centres, again, where we know that people often use drugs if they're admitted. Naloxone, we're going to hear lots about this today. Clearly, naloxone is hugely important, but as Deb pointed out, it's one part of the toolbox. So we definitely need to expand the availability of naloxone, but we also need to recognise if we give naloxone to someone and they've overdosed for a while and they've had oxygen starvation, they could wake up and have severe disability afterwards. So this is hugely important, but it needs to be part of this kind of wider package of harm reduction offers. Again, people will know, there's lots of anecdotal reports of people who've overdosed on synthetic opioids requiring lots of doses of naloxone, and there's some laboratory evidence that nitazenes are resistant to the effects of naloxone. So there are these arguments about do we give higher doses, but on the other side of that, there is the risk if you give someone naloxone, a really hefty dose, and they withdraw really hard, they're not going to be very happy about it. They're going to run off, and the half-life of naloxone is shorter than the half-life of quite a lot of these synthetic opioids. So they just go around the corner, the naloxone wears off, and then they've overdosed again. or they go and they use more heroin. So this is something we need to think about. And this recent guidance from OHID recommends that we use the same doses of naloxone, but you keep giving it, and you just aim to get people so they're breathing independently and not necessarily kind of fully aware. Then there's drug testing and drug checking. This was the spoiler. I think it's a good idea. So you saw that data that we have from Wedenos, and the hugely important thing here is we get to see what the drug actually is and what they think it is, which you don't get from seizure data. And we have, well, I won't talk about it too much because Katie's just about to, but we have a regular drug checking service in Bristol. And as far as I'm concerned, that should be expanded to other areas. And then also we've heard mention of nicotine test strips. I think there's a space here. We need some more evidence about the best way to use these strips, what the limitations of them are, how they affect behaviours. But again, potentially an important intervention in this changing context. So then on to the spicy bits. The other alternative and the kind of knee-jerk response a lot of the time when we have a new drug is, well, we have more controls about that drug. Everyone here will know, again, we have the Psychoactive Substances Act and the Misuse of Drugs Act in the UK. Under the Psychoactive Substances Act, production and supply of drugs is criminalised, but not the possession. And under the Misuse of Drugs Act, possession is also criminalised. And nitazenes have been moved across into the Misuse of Drugs Act. However, most people, at least, who are using nitazenes don't mean to possess nitazenes. They don't intend to use them. So the rationale for a deterrent effect of criminalising possession doesn't make sense. It increases the penalties for production and supply, which makes sense in the context of our kind of wider drug laws. But is this going to help? I think probably not. The profit margins here are huge, and we know that people are producing drugs because of those profit margins, and that's not going to go away. This is also incongruent with conversations internationally about whether we should be taking different approaches to drugs. So I don't know if you've seen the UN Common Position on Drugs, which was in 2019. So this was from the UN Chief Executive's Board of Coordination. It's all the executive heads of all the UN agencies, including the World Health Organization, UNODC. And they advocate for different approaches to drugs, including consideration of the decriminalization of the possession of drugs for personal use. This isn't going to solve the problem. If you decriminalise drugs, people aren't suddenly going to stop dying. But potentially it creates a more conducive environment to provide the interventions that we know are going to reduce harm. It's going to reduce stigma. It's going to bring people into services. There is no clear evidence that I'm aware of that criminalisation reduces levels of harmful drug use. However, it's clear that criminalisation causes harm. It's a punitive policy. It's in the definition. It's meant to deter people by harming them. And often people who have the most harmful patterns of drug use have other disadvantages, like socioeconomic deprivation, trauma, mental ill health. Criminalisation isn't going to help these things. It's going to exacerbate them, which could make more harmful patterns of drug use more likely in the future. I think a way of thinking about this argument is as the risk environment for drug use. You might have heard of this. It's from Tim Rhodes, who's an academic in the London School of Hygiene and Tropical Medicine. And he talks about when someone has harm from drugs, you don't just have that person and the drug, you have all of the context around it. So you have whether there's someone there who's going to call for help, whether they have support, what's going on in their lives, the services that are available, the harm reduction advice, the harm reduction interventions. And by modifying those things around that incident of drug use, we can increase or decrease the risk that that person faces from drugs. So I can't emphasize enough, I've just made these up. So this isn't based on numbers, it's quite difficult to quantify harm. But I think it's a useful conceptual aid. So in the top left, this is what we hope happens with drugs. You have more punitive policies, you get 50% reduction in drug use, you get a proportional 50% decrease in harmful drug use, and you get a little bit of harm related to the policy, which is disproportionately accounted for by the reduction in drug-related harm. Does that work? Or is it more like the bottom right? So sure, if you threatened everyone with the death penalty, less people probably would use drugs. But you get a reduction in drug use, but does the proportion of harmful drug use increase because people are doing it in riskier ways, they're using drugs alone, they don't have access to harm reduction interventions? And I think we often underestimate the harms related to policy by criminalising people. And then where it gets really spicy is, do we think about the responsible regulation of drugs? So this has recently been advocated for by the Office of the High Commissioner of Human Rights in the United Nations, also the Special Rapporteur of the UN on the Right to Health, various other UN experts, the Global Commission on Drugs Policy, which is made up of former world leaders and academics. And they advocate for a system whereby each drug is considered independently and on its own, and we take measures to try and reduce the harms that are associated with that specific drug. So that's going to vary with different drugs. So potentially you could get a drug in a pharmacy with a harm reduction intervention. Potentially it's on a prescription model, which is very much like what we have with OST. And the Global Commission on Drug Policy, again, this is totally made up, but again, useful conceptual aid, I think. They suggest drug control could be like this. So on the y-axis, we have harms, and on the x-axis, we have the model of regulation. At the right, we have a completely unregulated legal market. So that's what we had with alcohol 2 decades ago, perhaps. And on the left, you have a completely unregulated illegal market, which is what we currently have for drugs. By controlling the production of the drugs, by controlling whether people can advertise, where people can buy the drugs, in what circumstances, what information they're given, can we reduce the harm and get somewhere in the middle? So I've just run out of time, but one final slide. So in conclusion, nitazenes are here, and they are here to stay, and I think we are going to see more drug-related deaths in the coming years because of this, and we need an emergency response plan. So at the moment, rightly so, we're having kind of emergency responses in specific areas where nitazenes are detected, but often quite a lot of people have died before we realise what's going on, and nitazenes are everywhere. I think this is already becoming the new normal. There's no silver bullet that's going to solve this problem, like decriminalisation, regulation, harm reduction. None of this is going to make this go away, but I think we need more tools in the toolbox. And the character of risks that people face from drugs, about fluctuating potency, about the risk of overdose, about not knowing what's in those drugs and not receiving the right advice and measures to reduce those harms, that hasn't really changed, but it is exacerbated because nitazenes are so potent. So the approaches indicated to address nitazenes are going to benefit in terms of wider drug-related harms as well. There's a lot of very unhelpfully small references. That's my email. Really happy to chat to anyone. This was originally a presentation we both gave, so that's why Caroline's email's on there. But she's great. And if anyone has specific questions about the data or NP-sum, Caroline's the person to speak to. Sorry, I overran. Thank you very much.